So how do I hope that the physical therapists are going to teach the patient? Again, my relationships haven't changed. So what does your therapist need to teach the patient? Well, we've identified the mechanical flaws on our physical exam. We want to then restore the integrity of the kinetic chain, and that's going to help us reestablish normal function. Let's talk about function for a minute. There's intrinsic and extrinsic function. The intrinsic function is the internal processes. That's physiology, biomechanics, and neuromuscular function. The extrinsic function is the resulting movement or the outcome of all of the internal processes. Physiology is the healing of the tissue responses. Biomechanics is the kinematics and the kinetic chain. And neuromuscular function is either learning motor control or relearning it if there's been an injury and we've got to go back to learning it again. Extrinsically, the patient is going to integrate the physiology, the biomechanics, and the neuromuscular systems, and then you're going to wind up with a specific, purposeful, synergistic movement, which clearly you're not going to get unless you rehearse those specific functions. By the way, that dive was a 10. So in order to restore normal function, you want to restore the anatomy by getting the tissues to heal. If there's surgery, then you're going to correct the anatomy. Physiology restores the correct joint position and movement, and then you work on the kinematics, activation of muscles in the proper sequence, and then you get the CNS involved for the movement control. Postoperatively, we have some different issues. We have to protect the repair. We have to prevent stiffness. We have to restore mobility. But then, as with the non-operative patient, we have to restore strength, restore the integrated movements, increase the endurance, and then get back to function. The dilemma that we have, especially in the post-op patient, is if you do too much or do it too soon, then you inflame the joint and potentially compromise the repair. If you do too little or you do it too late, then you wind up with decreased motion, stiffness, and the patient can't function well. And all of this has been compounded lately by that. We have big problems. And one of the questions I get asked after this session every year is, what do you really do with your patients, because you can't possibly be sending them to as much therapy as they need? And that's where the physical therapists come in. And I rely on the physical therapist to teach the patient, and then it's the patient's job to do what they're supposed to do. So let's talk a little bit about the kinetic chain. There's open kinetic chain and closed kinetic chain movements. In the open kinetic chain, the terminal link is not loaded. It's freely movable, such as doing a straight leg raise against resistance, and the activation is usually from proximal to distal. So if you're having the patient doing shoulder shrugs and shoulder clocks, that's an open kinetic chain exercise. Closed kinetic chain, the terminal link, which is the foot or the hand, in the case on the left, a leg press, which is really a closed chain version of a leg extension, meets enough resistance to restrain the free motion, and then you wind up getting the muscle activation, which is sequential from distal to proximal. Well, what's the difference? Closed kinetic chain movements, the joint doesn't move very much, the accelerations are very low, resistance forces are very large, joint compression, which will protect your repairs. There's decreased joint shear, translation, and distraction. You stimulate joint proprioception, and you get enhanced dynamic stabilization because of the muscle coactivation. So there are clearly some benefits to it. So what are our considerations as we're setting up a rehab program? Well, we've got to control pain. We've got to get their motion. We have to, in shoulder patients, we want to work on scapular position. We have to work on their core, their posture, the kinetic chain. We have to think about the functional exercise progression. How much do we have them do? When do we have them do it? And then what do we do with their cardiovascular system? Because I'm frequently being asked by my patients, when can I? You know, when can I run? When can I get on a treadmill? When can I jump? That type of thing. So with regard to pain, it is not a no pain, no gain thing. I show this slide every year, and I can't tell you how emphatic I am about that. If the joint is painful, it will not progress. Rehab should be relatively pain-free. It is clearly not a no pain, no gain situation. If the patient's having pain, then they're either doing the wrong exercise at the wrong time, or whatever they're doing is causing inflammation, and you need to back off. I get my patients to the physical therapist early. I happen to be blessed with an absolutely remarkable physician assistant. She does the first post-operative visit with the patient. She'll go over their pictures with them, and she will teach them the basic program. Then we'll decide if the patient then has to go to a physical therapist. But the advantage of getting to the therapist early is the patient gets control of their own situation. The therapist can spend the time calming the patient down, outlining the goals, setting up a program, giving them an idea of what's acceptable pain and what's not, because it's very important for the patient to have that information for two reasons. One, because it helps them, and two, because it helps us. In the office, we don't get the phone call saying, I've got this problem, what do I do about it? And then we've got to have the patient come back in. But also the therapist, I rely on my therapists a whole lot to give the patient guidelines for how to progress themselves. With regard to range of motion for the orthopedist, I think it's really important that the patient's position in the sling be taken into account. You don't want the arm in internal rotation across the belly. We put our patients in basically in the scapular plane, and for posterior stabilizations, we go to the gunslinger position. It's really protected motion rather than immobilization. We teach the patient how to do bowing exercises at their first post-op visit. It's really a closed chain pendulum. What you do is have the patient flex their hips and knees, and by doing that, they can't fire their upper trap, so they can't start cheating on their scapular position. And then we'll have the patient move to closed chain ball rolls rather than pendulums, because again, there's less shear force on the shoulder. Moving to the core, the definition that I like to use is the ability to control the position of the trunk over the pelvis to allow optimum production, transfer, and control of force and motion to the terminal segment in integrated activities. This has been Kibler's definition of core stability. There's a difference between core strength and core stability. And what I frequently see from physical therapists is I send the patient for a core and lumbopelvic stabilization program, and they have the patient on a Swiss ball doing sit-ups. It's important that they be doing their exercises in a weight-bearing position. So Paul Hodges, a physio from Australia, has shown us how important the transversus abdominis is. So we incorporate that a lot. You heard Mark talking about that, and we're going to talk about that more this afternoon. If we can get our patients into Pilates and yoga, that's ideal. Yoga is going to help flexibility, and it's going to help strengthening as well. Not all yoga is the same. Some of you have seen this before. There's Iyengar yoga, and then there's the yoga that they practice where I grew up in the Bronx. Core stabilization, again, you can see that this is John Schlechter, who's a pediatric orthopedist who spent some time with me. And as he's doing his core and lumbopelvic stabilization, one of the problems that we had with him was that he pronated when he was weight-bearing, so he rolled up a towel and stuck it in his arch. But it's important to work on that and get that engaged as a part of the scapulothoracic rehab. Then we'll work into single-leg balance with modifications with rotation. We do this early. You can do this in a sling. You can engage the entire trunk and the scapular stabilizers by having the patient do what Ben Kibler calls lawnmower starts, where you have them using their legs, their core, and then they do a scapular retraction and depression as they come back. And then when they come out of their sling, then they can start doing it freehand, then they can start doing it with rubber tubing, and then they can start doing it with free weights. And you've got to be careful about scapular position. As you have the patient lift their chest, you will get more motion of the scapula and more motion of the glenohumeral joint. But you've got to be really careful, because when I asked him to show me how far he could get his arm overhead, he dropped his chin and he went into lumbar lordosis. So you've got to be careful about how the patient is substituting. As Mark said, we use a lot of biofeedback. We'll use biofeedback on the lower trap to teach them how to fire that, and we'll use it on the upper trap to teach them how to inhibit that. This is the picture that I showed you with the single leg squat. He also had a typical thrower's shoulder where the scapula was depressed. It doesn't make a whole lot of sense to have that patient do a scapular retraction depression exercise, because that's just going to reinforce the problem. His problem, and we don't have time to go through this, was that his upper trap was too long. So here we have him doing, basically it's a VMO set for the shoulder, but you'll see that as he comes down, his scapula starts to wing on the right. And so this young lady, this therapist who taught me about this is here.